The topic which we will be discussing today seems to be very simple, but actually it is the basis of whole anesthesia practice which we do. Okay. So I would like Mahjabeen or any other junior resident to take the lead. Okay. So I will start with Mahjabeen. Just tell me one thing. What do you know about preoperative assessment? How do you do preoperative assessment?
Assalamu alaikum.
Yes, walaikum assalam. Yes. How do you do a preoperative assessment? Like you are on duty and some of your colleague, senior colleague, or asked you to evaluate a patient. This will be one scenario, or the other scenario which you will not be encountering in some part of. I'm not sure whether it is developed in your hospital or not, because there is a proper preoperative clinic which is called as pre-anesthesia clinic, and all patients who are booked for elective surgery are supposed to go and visit and before clearance and before booking for the operation theater. Okay, so this is not there in every hospital, but you, whether you are sitting in the clinic or you are evaluating the patient in the ward, or you are evaluating the patient as an emergency. So what you do there, what you do there when you go there, what is in your mind? You have some information that that patient is coming for appendix, or that patient is planned for cholecystectomy, or whatever XYZ. So how do you assess the patient?
Yeah, I will first go to the patient and identify that patient, and then ask him that what is the purpose of his admission, and then I will start with the history taking
Okay.
and general systems of the body, cardiovascular, respiratory, and all other systems. Basic questions like is the patient hypertensive or uh, and that diabetic or not, and then I will ask that how much I will calculate the meds, and I will ask him that how much activity he can do, and then I will examine the patient um, regarding all the systems, and then the airway assessment, and I will plan this preoperative planning, that whether this patient will be on general anesthesia or regional anesthesia, and then for all the patients,
I
whether we are.
apologize, Mahjabeen. Can you just
Yes,
hold
yes.
for a second? Just hold for a
Okay,
second, please.
okay.
Sorry. Yes, I will come back to the question again. Okay. So each and every question which you asked, there should be a reason for it. Am I right?
Yeah.
Okay. Like if you just go back to start with, that you should be focused to start with demographics of the patient. Okay. Like for example, you just went directly to the diseases. Okay. But do you think the age, the sex, the occupation, the anything related to the patient has some meaning? Okay. Like if you are
Yes.
dealing a patient of 1 month or 1 year or 100 years, there will be a lot of difference, or 40 years. Okay. So some, and you are dealing a female patient versus a male patient. So there are some things which you will be considering regarding the, like for example, just correlate, there are more chances of post-operative nausea, vomiting in female patients. So this is a
Mm.
point. Okay. If you are dealing with extreme of ages, there are concerns related to that age. So everything will have some meaning: age, sex, occupation, personal habits. Though, so you can name this all in the heading of demographics, patient demographics. Okay. And you can include even some data related, basic data related to the patient. In when you are taking you are starting your thing, you can add. This is not exactly, this may come in examination as well, but when you are assessing the patient, actually objectively, the next things which you should be in your mind is the blood group, is the height, is the weight, because this data will be helping you or guiding you towards the further management. Okay, so anything related to the basic identity, the basic, like for example, if the patient has a denture, so this is something related to the patient. It has nothing to do with the disease, it nothing to do with anything else, but it will be changed, affecting your anesthesia management. So basic information about the patient will be your, should be your first heading. Okay, next, what next? You have to think in your mind all the steps of anesthesia, and whatever you are asking should be, there should be some correlation between that symptom, that sign, and the conduct of anesthesia. Okay, like for example, if some patient has any specific problem which is problematic for that patient, but may not be affecting much for anesthetist. Okay, and there may be something which appears to be not very significant for the patient, but that is more important for the anesthesia. Okay, so one of the most important thing will be, which you will be assessing to start with, will be the functional status, which you told METs. Okay,
Yes.
because all of the anesthesia care which you will be providing will be dependent on how much stress patient can take. Okay, how much uh, stress of anesthesia and cardiac depressant effects, and any stress which we are giving to the patient, the functional status will be telling you. So just if we just peep into this point, how you assess the functional status, what you ask.
And it's how much activity he can do
Mhm.
without being breathless.
Okay, so you can ask the patient to walking in the home to the bathroom, changing the clothes, and then next step will
Yeah,
be
and walking upstairs.
then the like horizontal walking, and then upstairs vertical walking. Okay,
Yes.
so by that usually if the patient is able to have two flight of stairs without being too much breathless, you will say that the meds are more than 4. Am I right?
Yes.
So
Yes.
for anesthesia, the meds should be more than 4. Now you have a scenario that the patient has osteoarthritis, or patient is having some fracture, or whatever the reason that patient cannot move now. Okay, so there are two options: whether the patient does not have the meds, or patient have the meds, but any other limitation is stopping that patient from moving. Am I right?
Yes.
So in that condition, this will be a question mark, that you cannot assess the functional class on the basis of history, because this will immediately guide this will be an indication for invasive testing later on if you have any intermediate or high risk surgery. So you have to do the, like you can say that you cannot assess the functional class. Okay, so if you add some risk factors, or if you have a more risky surgery, you should have the invasive testing before proceeding. So this small point, whether the patient is bedridden or whether the patient is mobile, will give you a lot of information. Okay.
Okay.
And then whatever questions you will be asking will be focusing on actually two things. One is the disease pathology, and other is the procedure to be undertaken. Am I right? So whatever
Yes.
questions after this discussion, this basic information you will be asking, that the questions will be related to the surgery or the conduct of anesthesia or disease pathology and the association of that disease to the like anesthesia. You will be extracting information from the patient, and you should have in your mind all the time the basic steps of anesthesia: intubation, maintenance, monitoring, recovery. So whatever you are asking, you should have, like, you should be making your questions objective. Okay. So this is the basic thing which you should do in the practice. Okay. So like, for example, if you name any disease for which you are assessing, like which patient you frequently assess.
Um, Actually, I haven't done any pre-op yet.
Any
So
case which you did,
I have read only
any
the theoretical
case.
part.
Oh, I understand. No problem. Just feel free. Feel free. Okay.
Okay.
Just tell me which case you want to evaluate. You name any case, and then we will look
Um,
how to pinpoint the problems related to that disease or the surgery. Then you will choose a surgery. So choose a disease, choose a surgery.
okay. Cholecystectomy. It's
For
very
a
common.
patient with which disease you are putting.
He might be diabetic or
Okay. Okay.
hypertensive.
Okay, we make both of them. So that the age will be around 50 now. Okay.
Yeah.
It can be in younger patient, but make it 50 years old. You want female or male, which more common in females. Okay, put 50
Yes,
year old
it's female.
female, 50-year-old female, female with the diabetes and hypertension for cholecystectomy. Okay. So
Okay.
now, what will be the concerns related to diabetes and what will be the concerns related to hypertension, which you should be asking? And forget about anesthesia. Remember one thing, because you are junior, you have not worked much. Okay. So, but still,
Yes.
forget about anesthesia to start with. What are the things in diabetic patient you need to know?
On how much time he has been diagnosed
This is one
diabetic,
thing.
and
Number one. Number two.
what drugs are on he's on, he oral hypoglycemics or insulin,
Okay, very good.
and
Number two. Number three.
is he compliant to the treatment?
This is will be in medications. Okay. Number three. This is 2 points.
Okay. And what else problems he's suffering from due to diabetes?
Very good. So usually then I will help you that usually there are either microvascular complications or
Yes.
macrovascular complications. Okay. For
Yes.
both, now I will label both of them where with hypertension and diabetes. Actually the same points will be valid for both diseases. Okay. A diabetic
Okay.
patient, the duration will have some implications, control will have some implications, the treatment patient is taking will have some implication, and the microvascular and macrovascular complication. We will not go in too much detail, but because I'm just giving you an idea. Okay. So usually the microvascular and macrovascular complications will be in the form of retinopathy. They are both in hypertension and diabetes. There is
Yes.
nephropathy, both in
Nephropathy.
diabetes and hypertension. And what about macrovascular complications? Like,
Mm,
very good. Like,
like heart diseases,
very good.
cardiac
Very good.
conditions.
Like ischemic heart disease, or yeah, you can say atherosclerosis, either in heart,
Yes.
either in peripheral system or in the brain. Actually, the ischemia can be there in three things. It can be there in anywhere, but usually either it will be the cerebrovascular disease, ischemic heart disease, or peripheral vascular disease. Okay. So all hypertensive patients can have all three diseases. Am I right? So this is
Yes.
one of them. What will be the result of cerebrovascular disease? The dangerous result will be
Stroke.
stroke. Before stroke, one point.
TIA
Very good. So peripheral vascular disease, TIA, stroke. Ischemic heart disease, angina, MI.
and MI.
And then next to MI is heart failure. Okay.
Okay.
So
Okay.
you will be pointing you should be just picking out at what stage patient is there. Okay. So what status of the disease patient have? Maybe patient has nothing. Okay. Or patient have a number of things. So if you say that patient has TIA or stroke, this is a clinical risk factor. Okay, we will go, because I'm just trying to touch everything. I'm maybe I'm going too much detail, but this is the most important thing. If you know, you will feel very easy whenever you are evaluating a patient. Okay. So, if you have this history of stroke or TIA, this is a clinical risk factor or intermediate risk factor. If you have angina, so angina, you have to classify the stage of angina, either at rest, either at minimal activity, either at moderate activity or severe activity. So it is on the basis of an Canadian class, usually Canadian class of angina. And similar that, like chest pain on at rest, chest pain at minor activity, chest pain at moderate activity, chest pain at severe activity. This is Canadian angina classification. And similar word, you change it with the dyspnea. So that is for New York Heart Association classification for heart failure. Okay. So in similar way, you can assess both of them. Okay. And because one of the preceder of ischemia or heart failure may be arrhythmias. So for arrhythmias, in history, you can have like history of palpitation. So palpitation, you can guess that maybe there is some arrhythmia going on. Okay. So like you will be in history, you will be asking these things and you will just making up mind, where do you stand? So similarly, you will be looking at the other implications, like there is diabetic autonomic neuropathy, or even in hypertension, because of the disease pathology, there will be sudden decrease of blood pressure, swings of blood pressure. Okay, so we will not go in that detail, but usually what you should be knowing, that what are the major effects of that disease. So now we will go, because this is a very detailed discussion where we can go take too much time on it, but usually you will be looking into the all organ systems, like kidneys, heart, brain, intestines, like anything you can add, and then you will find some uh, points related to that disease which are affecting your management. So your management will be like for example, if you have a diabetic patient, hypertensive patient, so one, in addition to the control, you will be looking at the optimization of the disease before, and at some points you will be canceling the case that the patient is not controlled, or patient needs optimization, or patient needs some change in the medication regime, like oral hypoglycemics, you will be converting it to insulin or things like that. Okay. Or you will be thinking that this patient is diabetic, so you have to give the anesthetic medications, titrated doses, because of autonomic neuropathy patient can have sudden hemodynamic collapse. This is one thing you will be doing. Or you will be taking invasive blood pressure monitoring, because you are expecting sudden change in blood pressure. You will be avoiding the stress response. So just considering diabetic patient or hypertensive patient, the next step in your mind will be these things which I am telling you: control, optimization, limits on which you will proceed with the case or cancel the case. Okay. So these things will be in your mind, and this same headings you can put to any disease. Okay. So the next step will be about surgery. Okay. So in the surgery, what you will be assessing?
That what type of surgery?
Very good.
And
So okay, what type of surgery is one thing, and how urgent is this surgery is other thing. Okay.
yes,
And what are the pearls or important steps or critical steps in that surgery. Okay. How much is the risk of bleeding? Okay. How much this surgery is near to the abdomen or thorax? Why? Because if it is high up, the upper abdominal or thoracic surgery, now there will be this area is involving the respiration. Okay. So this is one thing. And how painful is that surgery post-operatively? So these will be things which you will be getting, that how urgent is that surgery, whether it is to be done in minutes whether it is to be done in hours, whether it is to be done as a plan, like you have some weeks, or as a purely elective. Okay, so the first two words are interchangeable, emergency and urgent, and the next two words are also interchangeable, that is planned and elective. Okay, so what do you think, where should be cholecystectomy?
I think it won't be that urgent.
I'm sorry.
It won't be that urgent. Like it isn't an emergency procedure.
Very good. So it is not emergency, it is not urgent, it is planned, or
Yes,
it is elective?
yes, it is elective.
It is planned. Actually, it is
Yes.
planned. Okay. Because if there is cholelithiasis, or if it is there is cholecystitis, okay, it can be subsided, but it has to be done. Am I right? So you can
Yes.
plan, you can optimize the patient with some things like antispasmodic, infection, this, but you cannot delay it forever. Elective surgery is that you have, like, examples of elective surgery are like cosmetic surgery, bariatric surgery, knee replacement. These
Okay.
are actually elective surgery, cosmetic surgery. Okay, so actually these surgery are elective surgery. So but in simple word, because planned surgery they have not written in all the books, but actually there is a difference. So for you will put it as elective. Okay, but actually it is planned. Like you have to you can delay it for some time, but you cannot delay it forever. Okay, so this is the thing. And then again, the other factors which I told you: risk for bleeding, and positioning, and the incision, because whether they are doing it laparoscopic or open, this will decide your a lot of management. Okay, so whenever you are assessing a patient, see what is surgery, what is the extent of the surgery, what is the risk factor in surgery, what is the urgency of surgery, and what are the other things really, any special positioning, any critical step, like if they are doing it laparoscopically, the time at which they insert the trocar, this is a critical step. It can rupture any viscera or any blood vessel. This is one thing. The other thing is when they do the pneumoperitoneum, if the anesthesia, depth of anesthesia is not optimized, there will be chances of patient having vagal reflex. Patient can go in bradycardia. Then when they have put it full pneumoperitoneum, there will be effects of pneumoperitoneum on respiratory hemodynamic system. Okay, and it can creating a sort of abdominal compartment syndrome. Okay, and then the third step is that continuously CO2 is being absorbed, and then CO2 is creating a problem in creating raised ICP, raised CO2 level in the blood, which is stimulating the sympathetic system. There is tachycardia, there is increased oxygen, disturbed oxygen demand supply ratio. So this is the thing which you will be thinking. The surgeon is saying, I have to do it laparoscopically. So this thing, as an anesthetist, should be circulating in your mind. Okay. So now we are just coming to the conclusion. We started from the demographics. We thought, we evaluated I'm not going in the details, the cardiovascular system, the respiratory system, but usually you are assessing objectively. You are trying to take the symptom and trying to put it in your management, like anything related to which is disturbing the airway management, anything which is relating to risk of aspiration, anything which is relating to post-operative nausea, vomiting, whatever things data you are interpreting, you are trying to fit it. I have made a file for it, anesthesia planning, and you can, I will share the link for it, and you can have a look. Okay, so this is the basic information. Then you are in this next step, after these all assessment of the all the systems, then you will be going towards the examination. So in examination will be basic airway examination. Even if you are doing the case in regional, still you have to examine the airway, because any anesthesia, even local anesthesia, might need to manage the airway. So you are assessing the airway, you are assessing the general physical examination, you are doing the general physical examination. If you are giving any regional block, you are looking at the region, the area of spine, or any other area where, when you are planning, for example, you are planning femoral arc block, you did not examine the patient, and the patient has some infection at that place. So how will you give block? Okay, so this is important thing. Like for example, you are examining your general physical examination. A very important thing is to have the IV access, because this can create a big problem for you. You have to anticipate about accordingly. Okay, and then you will be going in the all system, the respiratory system. You will find any on inspection. I'm not going in detail. I'm again, maybe I'm wasting time in this word as well, but you will be doing inspection, palpation, percussion, examination, and you are finding the result will be, the result is not, this is your, because you are not a physician in that way, you are trying to make it objectively. Like if there is any stress, you are expecting post-operative complications. Intraoperative will be there, and actually in perioperative period, you can use the word that perioperative chances of increased morbidity and mortality because of that system, cardiovascular system or respiratory system or renal system or hematological system, whatever. Okay, so the history or examination, you have to convert it into risk factors. Okay, like pulmonary risk factor, cardiac risk factor, renal risk factor, risk factors for bleeding, risk factor for thrombosis, risk factor for whatever history you have taken. Like very important thing I forgot to tell is history of risk factor for thrombosis. Okay, because whenever you are doing any surgery, because of stress, there is procoagulant phase stage because of stress, surgical stress. Okay, so if you have a patient of old age or morbidly obese or bedridden patient, or a patient which will be bedridden post-operatively, so you have to consider it. There is a risk factor chart which will make make you yourself. There are scoring system to evaluate that thing. So you can learn these things gradually. We will discuss these things. Okay, but actually in this session I'm just giving you an insight that how you have to assess a patient. Okay, then on the basis of history and examination and risk factors, now you are planning for investigation. So what investigations, Mahjabeen, would you like to see?
The blood profile of the patient,
Like
and like CBC
hmm,
and the renal
in
function tests,
what will you see in CBC?
the hemoglobin,
Why hemoglobin is
uh,
important to anesthetist?
because uh, hemoglobin is important as we can see that in case of blood loss, that we
What
have to
happens?
replace it
Like if
by
you have a patient with hemoglobin, low hemoglobin, what is the problem?
hemoglobin, the oxygen supply, the oxygen
Very
lining
good.
will be
Very
reduced.
good. I will correct the word. In a layman, oxygen is traveling in the body on hemoglobin. So hemoglobin is the car of oxygen. So if you don't have the car, how will you roam around? Okay. So the oxygen carrying capacity will be finished if you
Yes,
have low
yes.
hemoglobin. So for maintenance of oxygen carrying capacity, you need to have an optimized hemoglobin. What else you see in the CBC?
The white blood count
CBC, like there will be chances of infection. You will be looking at what else?
and the
Anemia profile.
platelets. Yes.
Yes, platelets also. And is only the platelet number is important, or anything else is important? Platelet function. Okay. So how
Okay.
can you assess the platelet function?
The clotting profile.
Bleeding time, clotting time. Okay.
Yeah.
And there is any specific specialized test, that is platelet function assay. Okay. So and there's some reactive inflammatory markers like
CRP and uh,
ESR. Okay,
yes.
this will be telling you some information about any infection going on. Like you will be treating, if you are having the clinical picture and then you have some inflammatory markers, you can think that this patient might be in going towards sepsis. Okay, so this is, and the other profile is related to the anemia, MCH, MCHC. We don't see actually. And there is another important thing which whenever you are looking at CBC report, you have to see in the hemoglobin. And what else? Similar friend of hemoglobin is hematocrit. So do you know the
Yes.
relationship between hemoglobin and hematocrit?
No.
Hemoglobin, for example, if you see hemoglobin is 10 and now you see hematocrit is 25, what does it mean? Or 20, for example.
Um,
It is
it might
showing,
be due to
is showing that patient is dehydrated. Usually
okay.
usually it is 3 times. Okay. Usually it is 3 times. Like if hemoglobin is 10, hematocrit should be 30. Okay.
Okay.
So if it is, for example, you look at the hemoglobin, maybe you are finding hemoglobin as 15. Okay. But you see, look at the hematocrit, it is 30. So you will say, doctor, surgeon, patient is hemoconcentrated, patient is dehydrated. So actual hemoglobin is not this one. So you will be looking at the hematocrit. Okay. Then uh, next step, you told renal function, liver function, clotting profile, coagulation profile. Okay. So you should be knowing that there are specific indications for doing preoperative testings. Okay. Like if, for example, you have a patient with no history of liver dysfunction, you don't need to do PTA PTT, because unfortunately we are labeling it as baseline. There is no baseline concept of baseline investigation. They have never used in clinical academic forum the use of baseline. There is no baseline. CBC to see this, electrolyte to see this, liver function to this, see this. Okay. There is no concept of baseline investigations. Okay. And your investigation should be objective. Make a habit that whatever investigation you are doing, there should be a reason for it. Okay. And you will find, like in hypertensive patient, electrolytes, the medication for the control of blood pressure can cause electrolyte imbalance, diuretics, ACE inhibitors,
Yes.
things like that. You will find some reason. Liver, for example, if patient is taking any medication which can have any hepatocellular damage or any obstructive problem and any metabolic problem, then it will be affecting the liver functions. The enzymes may be raised, protein may be low, and the coagulation factors which are being synthesized from the liver will be decreased. Albumin level will be decreased, and AG ratio will be disturbed. So these are next steps you will be looking at. But actually the baseline, that how you are interpreting. Okay. And then the common investigation other than blood profile will be specific to that disease. Thyroid chemistry, thyroid hormones, thyroid scan that will be related to it, and any other radiological studies which you are doing that will be specific to that. We will discuss in detail, but there will be some investigations which are related to the disease pathology. There are some investigations which are related to the basic conduct of anesthesia, that if you have any problem in liver and kidneys, you will be very cautious in giving any medication which have more metabolism or renal excretion. You will be trying to use the medications which has less liver metabolism or effect on liver metabolism, like, sorry, they are less dependent on liver metabolism. Okay. Which are less dependent on renal excretion. So this is the interpretation of what you are doing. Okay. But usually there will be specific investigation related to that surgery or that disease that you should be keeping separately. Okay. And there will be something which is related to you. There may be intercross, but actually you should be thinking in that way. Like um, uh, I told you that I gave you example of thyroid. There will be some other similar examples. Okay. So now come to the common other ECG, chest X-ray, echo, and specific cardiac investigations will be according to the risk factors, according to the overall picture. Like you don't need to do ECG. Will you do ECG in a 35-year-old male patient without any risk factor?
No.
No, unless you have a surgery in which there may be some need of, like there will be severe hemodynamic stress, or if you are using any agent which can affect the heart, then you can have a baseline ECG. For example, if you are a patient initially is not diagnosed, but he is going for example, this patient is going has a trauma now. Okay. and now or any impending problem, then in that scenario you can do it. Otherwise there is no indication, a clear cut indication. Okay, so similarly echo, when you are not able to assess the patient physical activity or you have some risk factors, you will be doing echo for that thing. Then we will be discussing shortly on Saturday. We have a session on cardiac. We will be starting cardiovascular system. Okay, on weekly basis, we will be starting specifically cardiovascular system, and then these discussions will continue. Okay. So similarly, like specific investigation, and then you will be making a plan for conduct of the anesthesia. Okay. So any questions up till now? And
No.
I tell you, the people who are going in the long case for our final exam, actually, I tell you something, that these are the things on which they caught the students, because they don't know these things which you are, mashallah, you have very good baseline knowledge, and best of luck to you for further progress, because majority of even the people who are going for final exam don't have clear concept of the things which we have discussed. Okay. So I just wanted to have a small discussion today. I just have some assignment to do. So tomorrow I will be having a discussion because tomorrow is off for me. So I will be taking a session around 3 p.m. Okay. And day after tomorrow, there will be a session on cardiovascular system. Okay. Any questions, please?
Sir, I have a question regarding OCPs. Should we stop OCPs before surgery?
Actually, these things, any medication, like for example, remember the thing, risk versus benefit. Okay. So whatever you are doing, one thing is risk versus benefit and implications for, and this is actually, I forgot to discuss because I just try to wrap up the topic, but there is very important thing in optimization. The word optimization is regarding medication. There are so many medications you need to continue on. For so many medications you may stop or may continue, and there will be certain medications which you have to stop. So OCPs, actually it will be depending on the scenario. Okay. So it is not your decision. If the patient is taking OCPs, it's not a contraindication for anesthesia. What will be the implication? That is important. So what will be the implication, Usman?
So there will be increased chances of thrombosis.
Thrombosis. Okay. So this is what you should be doing, because this is not your decision to stop OCPs. Okay. This is not your decision. If the patient is on
Because,
OCPs,
sir, in some books I have read that you have to stop for, I think, 4 weeks before surgery.
remember one thing.
I don't know.
Yes, this is one thing that what is the effect of it. If it, that is, remember one thing. If you are only going for the oral part, never use this word that I will stop it. You will say, I will have a discussion with the obstetrician and I will evaluate the risk versus benefit. That on this answer, no examiner will fail you. I can guarantee you. Okay. So these are tricky things. I don't know why to stop for 4 to 6 weeks, Usman.
Sir, I still can't find the answer, but I have read in somewhere that you have to stop for, I think previous guidelines, or I
If
think
you,
some.
I can one thing I can be sure, that if, for example, patient is taking OCPs and now you stopped it, you will find her pregnant. Okay. So I don't think so. It has any relationship. If you, this is what, because OCPs are steroids. So you will be just take this patient as a patient on steroids. Am I right? I don't know exactly how much dose is there, because your question is absolutely valid. But I don't recall any specific reason to stop OCPs other than this, that you will be anticipating it, and you may give just like we discussed, that if you have risk factors for thrombosis, you are having either good control, or you will be reducing all the factors. We will be discussing embolism, thromboembolic disease in detail sometime. And you have to decrease the risk factors. You will be giving good anesthesia. You will be reducing the stress response. You are keeping the patient well hydrated. You are treating the brain with multimodal analgesia. You are using the minimum invasive anesthesia. You are trying to have regional anesthesia. You are trying to have like central nasal
Okay,
block.
sir. One thing, sir. Every time when I Google this, when to stop OCPs before surgery, I got the answer from Google that many women are now advised not to take birth control pills from 4 to 6 before elective surgery because of the serious thromboembolic complications. You
Yes,
know, every
yes,
time I Google it, I get the same answer.
yes, yes, yes. But I tell you something that I have told you the rationale. Okay. So
Yeah.
yes, I
You know,
don't think so. This
Medscape, academic, if I Google it, in Medscape, in academic.oup.com article, in PubMed, everywhere it is written 4 to 6 weeks you have to stop.
Mhm.
So that's why I'm much but confused. In
Mm,
Pandia.com, in
actually,
gpnotebook.com, so many
actually,
things.
this will be a regional regional consideration as yes, Dr. Humera.
Sir, I want to know that how much is the risk of MI in a patient with reduced ejection fraction or diastolic dysfunction?
Uh, what we say, what the media people say, stay tuned. We will come back soon with the detailed cardiovascular system. But of course, correlate it. Low ejection fraction means the heart is going in failure. Okay. So when the heart is going in failure, there is decreased perfusion anywhere. And when decreased perfusion anywhere, there are chances that when the stress of anesthesia comes, the requirement is even increased. The supply is decreased. The requirement is increased. So there are definitely more chances of patient who the heart which is already failing, already not able to maintain the perfusion, to go in ischemia. Okay, so this is the myocardial oxygen demand supply ratio. Okay. And Usman, I think you have a very, very good question. This is actually a good question for discussion, but I have told you the answer for the oral examination. But I don't think so that anyone will be asking that. You can quote the same thing that you have to discuss with the obstetrician, and if there is too much risk, then you will avoid it. But if, for example, if you have, of course, this will be in fertile age, and usually females of fertile age are protected from God. They have hormones like that. They are they have a protection from any problems. Usually all the problems come after that. Am I right?
Uh,
So
yes,
but
sir. And sir, what about the MAO inhibitors? We have to convert it into reversible short-acting MAO inhibitors, and we stop at 12 hours before surgery. Is it the latest guidelines, I guess?
Osman, I am sorry. I have short of knowledge, but this thing I again tell you that more important thing is that you will anticipate. If you will find a patient like that, you will be avoiding what, like MAO inhibitors. What will you avoiding?
I would
Indirect
avoid indirect
indirect acting.
initropes or adrenergic
Yes, that
agonists.
is that is the most important thing. And you will be avoiding all the medications which can release catecholamines like ketamine, ephedrine, tramadol, or any
Yes,
medication
tramadol.
which is
Yes,
causing
yes.
tachycardia, pethidine. Okay, all the things which can increase the stress you will be avoiding. Regarding the stoppage or continuity will also be dependent, again, risk versus benefit. If you have a patient who is really depressed and you stop it, there are more chances of having some post-operative delirium, or any
Yes, sir.
like.
Again, I have read somewhere that you have to discontinue the reversible, irreversible blockers. Sorry, reversible irreversible, and then you change into irreversible, and you stop at 12 hours before surgery, and then you start again after 12 hours. I think I've read it.
Yes,
I'll
it will be
confirm
it will be
again.
like that. You can again use the word that I will be evaluating the patient. I will be discussing with the psychiatrist. Okay, because actually make a habit. Yes, one of the things which I forgot to tell you, Mahjabeen, especially that you always try to find any referral, any discussion with other teams.
Yes,
We-
multidisciplinary. Yes,
Multidisciplinary team, this thing should be in your mind. Okay.
examiner wants to listen this word.
Now listen to, and even because in the learning phase, you should be in my mind that I tell you that I am the sufferer. That's why one exam I answered almost everything. I had some of the giggles, but actually at the end of the, when I was about to leave, the bell ring, and the lady asked me for a von Willebrand disease patient. I had not named even a hematologist. I told everything about desmopressin and everything, but I did not use the word hematologist. So when the bell rang, the examiner said, "Would you like to consult a hematologist?" And I looked at her face and I knew that I will be failed. And I was failed. Okay. So nobody, I know, I can never forget that what is the role of multidisciplinary team. Okay. So I hope
Okay.
this session was valuable again, because I am doing a jihad against the specific one book reading. I have no other impulse. I want to save my fellows, my friends, from the misery, from the trauma, from the disaster, any bad word, for the one book reading which will throw you in a tunnel of disaster. Okay, so if you are in 2022, please break the shatters. Please make yourself above the reading of single book. You go roam around, try to find the rates of all the products, and then try to make your customized product. Okay, because that will be the best. Thank you, and inshallah we will meet tomorrow around 3 p.m. Pakistan time and 1 p.m. Saudi Arabia time. Assalamu alaikum.